welcome and thank you for joining us. You'll just have seen there that we are recording this, so you might want to bear that in mind if you are saying things, but we would encourage you to be as interesting and controversial as possible. This is part of a little series where we want to sort of take an idea that's got common currency in health policy and management and really kick the tires of it and ask the question, is some of the commonly held views on this correct? Are there hidden pitfalls or missing opportunities that lurk underneath some of the sort of headline ideas that go with these? And there's quite a lot of reflects an anxiety I have generally, that there's quite a lot of what you might call well-known facts in healthcare policy and planning, which when looked at may be well-known but aren't actually facts, or they are, but they need nuance and a deeper understanding of them for them to be accurate. So this is the first in the series, and we wanted to look at some of the assumptions that people are making around skill mix and substitution, and really ask the question: have we been going in the right direction here? Have we been making mistakes? Are there opportunities that we could exploit that we haven't done so far? And are the reasons to be concerned? I've increasingly become concerned, given the epidemic of burnout that we've seen across the world, about the phrase "working at the top of your one's license," because I'll be honest here, I don't do that the whole time, and if I did, I'd probably have to go and lie down after lunch on Wednesday for the rest of the week. So there is something about being able to think about this a little bit more deeply and cleverly that we're going to do today. The next one is going to be looking at the idea of we need to shift shift resources to the front line, which is a sort of shorthand for looking at the question of actually should we be investing a bit more in management administration than we've traditionally done in the NHS. So as said, we're recorded. And we're going to get going. We're going to get two bits of input from our speakers, and then really invite you to actively participate. And there are two ways in which you can do that. One is put your ideas in the chat, which we'll be monitoring, and we might call people to come and share their comments in the chat with the wider group, or use the traditional stick your hand up route, and we'll try and bring you in. There's quite a lot of people in this virtual meeting, so we hopefully we can get to you all, but I hope you'll understand if we can't. And we're going to try and finish at the advertised time of about 1:30. So without further ado, great pleasure to introduce our two experts. The first is Professor Alison Lilly from South Bank University, who, if those of you are on Twitter and follow this particular issue, will see that she not only has a great level of expertise and knowledge in this area, but some fairly trenchant views, which she's going to share with us in a minute. And then we're going to hear from Dr. Llewellyn Vaughan, who's a senior clinical fellow here at the Trust, who's also been thinking about these issues from a slightly different angle and has been involved in a number of projects in which this particular issue has been a key question. So I think, Alison, I'm going to hand over to you, and I think you're sharing your screen, and let's proceed. Thanks very much.
Thank you very much, Nigel, and thanks everybody for coming along. I'm not sure my views are trenchant. It's just that I've got a fairly strong desire for evidence-based practice, whether that's in workforce or clinically. So it is very much informed by that. And I thought I'd really like to just take 10 minutes to talk about, I'll just share that. So hopefully everyone can see that. And I'm a bit of a workforce nerd, so I'm a professor of modelling, and I've modelled many, many different things across different sectors. And one of the things that we find in the NHS, because I regularly scrape the NHS jobs website, is there are around 77,000 different job titles in the English NHS alone. Once you take specialisms out, it comes down to about 56,000. And I have become fascinated by these new jobs. And of course, as industries evolve, you need new workers, you need different types of workers. But healthcare has taken a particular way of doing this, is perhaps very different to other safety critical industries. So many years ago, I used to do some work with an organisation called the National Cancer Action Team, if you remember them. And they oversaw cancer reform in England in the sort of mid-2000s. And from that, we made an evidence-based role. So we saw that there was a deficit in labour in cancer, and the evidence-based role was the cancer MDT coordinator. There was a lot of administrative work around cancer, a lot of tracking work, particularly to make sure people didn't fall down the gap. So it's a safety aspect. And so the MDT coordinator role was born. It was usually a band sort of 3 or 4, maybe a band 5 if it was a big MDT. But it was based on a deficit of labour. And in recent years, what we've seen, so we modelled cancer, the cancer workforce in 2019 again, is an explosion of different types of roles that have different types of functions. So you've got the cancer MDT coordinator in the middle. And in London alone, there were 30 different variations of this job. Some were clinical, some were not clinical, some were a mixture of both, some were support workers. They varied in pay from band 2 to band 6. And essentially, they also, because they essentially filled a gap of perceived need rather than evidence-based need, had different levels of effectiveness. And so that's why I became really interested in how these jobs evolve. So you've got different types of jobs fulfilling different types of functions, but then sometimes big parts of the work not being done. And I really started to think about the way that healthcare workforces are designed and realised actually they primarily weren't designed. So one of the big issues that we have is that Taylorism is very, very embedded in healthcare workforce planning. Workforce planning in healthcare is based on supply, who we can afford, what kind of people, how many people we can train, rather than demand for labour. And when there is sort of a kind of demand modelling, it's based on activity and not actual demand for labour. And that makes it that means there's usually a deficit. The focus is also, because of Taylorism, I think, based on this sort of task-based technical competence model. So then you get the sort of the employee seen as a vessel of skills, and actually you can pass these skills around, and there's a sort of overlapping technical jurisdiction that people can all do the same job. And all you have to be is technically competent to do that job. But in any safety critical industry, including healthcare, there's also the application of knowledge and skills. So praxis, the development of that sort of knowledge and skills as applied, and that technical skill as applied, it's actually really important. But it leads to a couple of fallacies. It leads to you could just upskill people technically and then they can do another job. It leads to top of the license thinking that productivity is the most important thing. And I think Nigel actually spoke about that very eloquently. It forces the sort of division of labour manufacturing model that you can take very, very complex work, chop it up into bits and give it to different people. And it also promotes the sort of the fallacy of the universal worker, the widget workforce, that you can just take people from one area and put them in another area and they'll function with the same level of performance. I think what primarily drives this is a lack of understanding of the work that's actually done. So I think that's one of the reasons that Taylorism and also things like top of the license have really persisted. I mean, it is the language of management accountants. It is the language of productivity. It is not the language of safety critical industries, where you shouldn't burn your workforce out if you want them to be productive and you want to retain your talent. What it's also led to is what we think of as taskification. So the division of labour model and a technical competence only model means that as long as you're technically competent to do something, you don't need to necessarily understand the context that you're doing that work in. As long as the activity is achieved, as long as the task is achieved, then in some ways the outcome actually becomes a secondary point. We see this a lot in nursing. So what we see is the addition of people that can achieve task added to the workforce. So people like support workers, given checklists. When we know adding more support workers, and there's a fairly substantial body of evidence on this, doesn't actually improve patient outcomes, but adding more registered nurses does, adding clinical decision makers does do that. So one of the reasons that this actually puts more pressure on the workforce, if you dilute the workforce, and we're seeing this emerging from several studies now, including some of the ones that we're doing, is that if you just add more and more, perhaps less qualified or less experienced workers, so more hands for least money, what you have is dissatisfaction of the workforce that's then becomes under more pressure because they have to supervise more people and they're accountable for more people's work. This was an example of some work we're doing in midwifery, but we also see this quite a lot in most of the professions now. And it'll be really interesting to see how this works with the mass expansion of the support workforce in the allied health professions. So it's essentially more hands don't necessarily mean less work for some workforces. So in fact can cause anxiety and actually be quite a damaging thing. So these are I thought it might be interesting to contrast the two models. So what we have, the triangle there on the right, is the sort of NHS model. You've got a smaller registered workforce and you put more and more people in, and it doesn't matter what those job titles are, and you put more and more people in, and hopefully the work gets done. But it does put a lot of pressure on those other decision makers. And it doesn't matter actually if they're clinical people or managerial people. Having to supervise less experienced staff and people that can't make decisions just defers decision making down the line. What we would tend to do in most other industries, and in fact we're trying this with some NHS workforces, is what we call a distributed model. Once you understand the work is done and where the deficit for labour is, you can inform skill mix much more intelligently, I think. So this is a technical workforce, a registered workforce in the NHS that is currently under a huge amount of pressure, that is facing the frontline skill dilution model. But when we actually looked at their work in detail, what we see was actually they need this mixed model of workers to redistribute their work. And generally, when you do this, people are a lot more satisfied with their working lives. So my reflections on this, having done this for a number of years now, is that workforce and these new roles are often not evidence-based. They are not driven by demand for labour. Activity is used as a proxy, and people imagine almost. So workers imagine versus workers done, if you're familiar with Eric Holnagel, people imagine what the deficit is without actually exploring what the deficit is, and then fill that space with a new role. A lot of the new roles we're seeing now are skills and tasks based rather than based on outcomes. So the safety critical work is not the focus, achieving task is the focus. The really big one for me is that new roles don't always solve old problems. If we have problems with retention and we have problems with workforce working practices, any of those things, putting new roles into those environments, those new roles will just experience those problems. We're seeing this now emerging with new workforces like nursing associates who are meant to supplement the nursing workforce, but now substituting the registered nurse workforce, and they are experiencing the same kind of poor working conditions. The new roles are risky, and it isn't so you shouldn't have them, but there is risk. So for existing workforce particularly, so we've seen this with advanced clinical practitioners, great idea, fills a gap perhaps more in towards the medical workforce than the traditional advanced practice roles, but it means the traditional advanced practice roles then go out of vogue. And we need some of those traditional advanced practice roles. So we need district nurses, we need clinical nurse specialists, we need extended skills AHPs to make the service function and function safely. But for example, in the district nursing workforce that we work with, many were told you become an ACP or that's it. So you get this kind of, it's like a workforce Tetris, but it's pushing out the other sort of functional roles. And then, of course, new roles, and you introduce a new role, there are sort of sociological aspects to that. And so things like incursion onto other people's territory, there's a fight for jurisdiction. There's an awful lot written about this. It's one of the reasons we don't really like substitution, because it brings around quite a disruptive way of introducing new roles. and it can really cause issues with sustainability. So we've seen this with the assistant practitioner, actually a really good role, a fairly well thought out role, introduced in sort of the late 2000s, foundation degree, but then the nursing associate, which was largely a non-evidence-based role, came along, a replication of the enrolled nurse, and has pushed out now and devalued the assistant practitioner role. So we've talked about more hands, not necessarily meaning less work. And of course, division of labour is risky. In complex work, division of labour is risky. You need people that are capable of joining all the things up together. And interestingly, when you look at things like prevention of future death notices from coroners, one of their most cited concerns is misdelayed or uncoordinated care. So those joining up roles, those roles that oversee things, whether it's administrative, managerial, clinical, might be a clinical decision maker like a clinical nurse specialist, are actually really important to keeping the system working. And it's also important to think about people's social identity. A lot of people, particularly people that train as registered healthcare professionals, have a social identity within that profession, and that's really important. And also not thinking of work simply as a series of tasks, but also practice. So praxis, the application of knowledge and skills in different and often unpredictable situations. So that's it from me as a bit of a whiz there through. I'll leave you with my take home, which is new roles don't always solve old issues. And you have to understand the work in its entirety really before I think you need to understand what the gap in the labour is and the gap in the skill mix is. And my favourite quote on workforce at all is, if you think it's expensive to hire a professional to do the job, wait until you hire an amateur. That's from Red Adair. The value of frontline expertise and decision making rather than deferred decision making to lots of different people can't be underestimated. And here are some references if you're interested and would like to read more. Thank you.
Thanks, Alison. I wonder maybe we could stick those references in the chat. If I think one of our team have got your slides, we'll do that. That was a brilliant whiz through the issues, and slightly, I suppose, depressing, but certainly evidence-based. But just thinking more positive, are you got in mind any really good examples where people have used new roles, substitution, or other approaches to thinking about skill mix in ways which have actually been positive and helpful? Because I think you've really laid out a number of ways you can not only do the wrong thing but do it badly as well. Have we got any examples where people have perhaps done this well, done a good design and implemented it well, that spring to mind?
There have been some by designs. I think things like the cancer MDT coordinator and a lot of the cancer roles actually were evidence-based and implemented well. The assistant practitioner was a really good example as well. It was based on the deficit of labour for registered nurses, but as a support for registered nurses, not a substitute. And I think there are some really other good ones. So we're seeing them particularly in specialisms, people that work in specialisms because they know their work very well. So for example, workers such as psychologists, although they're very rare, they're like hen's teeth, can really help with workload redistribution. We've seen that in several areas in long-term conditions. So adding a psychologist to the MDT can really help with workload redistribution and also optimize care for patients. So there are actually quite a lot of examples. It's when you get these sort of big mass policies that perhaps are a reaction, that it can kind of not go so well.
Great, thank you. I see Minesh you've got your hand up. Would you just hang on for us, because I think we'll get some input from Luella now, and then we'll have an opportunity for responses and thoughts based on that. So thank you, Alison, and Luella, over to you.
Thanks very much, Nigel. So of course this is the tricky part of it, which is that I'm trying to do something which is skills based. So let me see if I can just. Right, can you see this? Can you see?
Yeah, we got you.
Okay, so what I'm going to say does in fact overlap a little bit with what Alison has said, because of course she's an expert, and in my reading I've repeatedly come across her work on this. She is an expert, but my own view of this has been informed by the work that we've been doing for a long time, particularly around smaller hospitals, And then we've been doing a more recent piece of work around the risks and benefits of regulation of advanced nursing practice for the NMC. So my issue in this has been initially from a much more practical point of view rather than an academic one, but obviously my academic reading has led me directly to Alison. So I'm going to take a slightly different tack. So I'm going to give a couple of positives, a couple of negatives, and then a couple of the unintended consequences, because I think that for me, that's the really interesting thing about all of this. Now, the positives are really well articulated. The whole purpose for coming from this in the NHS was from the 5-year forward view, and the stated explicit rationale was for a more flexible and more responsive workforce, particularly in response to the ageing population, and as we said, the relative deficit of particularly doctors, but also other sorts of healthcare workers. It is quite clearly a boost to retention, and it's retention first, because most of these advanced roles sit with experienced practitioners who have been working for some time. But it does also lay out a much clearer career pathway for people who are entering in. And I think that the thing that's interesting about that is that, again, the practical point of it is that it's to keep good clinicians clinical. Traditionally, particularly in nursing and medicine, if you want advancement, then you have to go in through a managerial route. And that's not attractive to large numbers of people. And so this is a way of actually retaining your good clinical workforce, and you're not taking them off the shop floor. And as we've heard, it's an excellent opportunity for skill development and variety, and that keeps you fresh and it keeps you intellectually engaged over what is really a very long career. Certainly in nursing, once you get to a band 7, which might take you under 10 years in order to achieve that, you've got a good 25, 30, even 40 years of your career left. You're really going to do the same thing day in, day out, all of that length of time. So this gives some new opportunities. And of course, there is evidence that it does produce better patient care. Patients, to a certain extent, are not necessarily quite so worried about who does what, so long as the what is done is actually done well. And where patients have received care from other sorts of practitioners, they're usually quite satisfied with the care that they receive. So there is no doubt about that. Right, a couple of the negatives. Now, Alison has already touched on this, and I'm really interested in this issue of task versus cognition, because one of the things that's been very striking to me about my own career is that I was excellent at task as a senior registrar. I was stunning. There weren't too many, practical things that I couldn't do. But I have not so much put in a Venflon since I became a consultant, which is about, 16 years ago. So I'm quite anxious about the junior doctors strike because I can't actually do most of the basic tasks now that a junior doctor can do. Everything that I do is about this. It's around complex decision-making. And a lot of the new roles that are coming through are specifically orientated around diagnosis and prescribing. And so there's this really interesting issue of, is this way of assessing task and competence and breaking it down to this little bit, is this really what we should be training people for? Really, it's around cognition. If you want people to diagnose and prescribe, you have to teach them how to think properly. And I think this is a really interesting tension that sits within all of this. And then, as Alison has also touched upon, there is this issue of role expansion, which I think is great, versus substitution. And I'm going to say the unsayable because this is the thing that creates most consternation in all sides of the debate. And let's be quite specific about this. There was a specific instance where a hospital advertised for a consultant role, but then said that someone who had come up through the advanced clinical practitioner route would in fact be eligible for this job. Cue meltdown on both sides of the Twitter debate. And I think there are really very interesting questions in this about the value of the doctor, the value of different types of professional groups, and what it is that you're training people for, particularly as we come back to the fact that the evidence shows that the difference between a consultant and a registrar in medicine is around strategy versus tactical issues and how we train people for that, and are they equivalent? And I think that this comes down to the next point, which that there are very clear, the way that doctors' roles are evaluated and they are assessed legally is very different from the frameworks that exist for other types of practitioners. And this at the moment is a really major issue. We also have competing frameworks that exist. So in the short piece of work that we're doing for the NMC, there are multiple frameworks about what advanced practice looks like, including right down to very specific leftover historical things that are kind of hanging over. But actually, if you want something that's consistent across the piece, getting to grips with the fact that there are competing frameworks, both internally, even within England, and then across the devolved nations, and then you start to think internationally, this is quite a problem. And of course, regulation and assurance, and it's not just regulation per se, there's other forms of assurance. The NMC and the GMC are not the only organisations which are in charge of assurance. This is something that is in fact problematic. And then we also, as Alison has touched upon, so Kath Checklin's recent work has emphasised the problem of supervision and governance that comes with oversight of these sorts of roles. And that's just not from doctors overseeing them, but actually assurance within their own group. So for example, for ANPs, there's 60,000 ANPs. There is some appraisal in place for all of this, but if you're going to really step it up, that's a huge amount of additional work for the existing senior workforce, and that does need to be considered. Right, the unintended consequences. Now, this is the bit that I think is really interesting. Now, as Alison has already touched upon, it is really just the Wild West out there with regard to job titles and roles. And quite often, organisations have development for their own needs, but sometimes they've been developed for one specific person in mind. And then what do you do when that person leaves? And I think that creates a really interesting problem. Alison's own work and work that we've done previously at the Trust, and we're repeating again, has shown that the pays for these sorts of things range from band 3 to 9. And all of this creates a massive amount of confusion for everyone. So both the individuals understanding what their job is meant to be, so they might be in one job and go to something that looks the same on paper, but in fact actually turns out to be completely different because you can't capture what these things actually look like. Employers, co-workers, and also the public. And I think that the public in England, England has an excellent reputation, even although it might be thought otherwise at times, for actually ensuring a very high quality of workforce. And so I think that the issue of there being any doubt around any of these sorts of things is actually really very important. The public assumes that whoever that they see are really genuinely competent to do their job. And if there is a problem, there is an appropriate route for redress. And as I just said, the frameworks for this in insurance is not yet in place. Alison introduced me to the idea of the performance gap, which has since been expanded upon by others. And I think this is also really interesting. So when new roles tend to start out, it's the keen beaners who take them on. So it's the people who are already tend to be excellent at their jobs who wish to take these on. And so when you have a small workforce in these new roles, people pretty uniformly tend to be good. And then you want to grow them. But actually, as you start to grow these things and more people start to come through, poor performance becomes more common. And actually then the overall level of everyone tends to drop. So just what your workforce looks like at the start is not necessarily where you end up. And the assumptions around that, again, I think are really quite problematic. One of the really interesting things that has come out of some of the work that we've been doing is that the poorer performers actually tend to choose jobs with less supervision. So we've come across a couple of examples where hospitals have been attempting to grow their own roles and workforce around this. And then what they find is that the people who can't come to grips with it don't go back into their old jobs, because why would you? Because you're going to be paid less. They actually tend to leave the system where there's oversight altogether and go elsewhere. Well, where do they go? Well, they become locums. They go into general practice. They go into third sector. They go into charities. Which again, because they're not in the NHS and they're not linked into HE and the frameworks and all of those sorts of things, the issue of assurance becomes really quite problematic. And I don't think we can ignore that. And the other really interesting thing that I came across in our medical generalism work was the notion that it really just does exacerbate shortages everywhere, elsewhere in the system. So we came across, again, a number of good examples where trusts were doing the right thing and they were trying to grow their own workforce to substitute for the fact they're smaller hospitals. It's hard to get, it's hard to get registrars, hard to get consultants, and looking at ways of expanding their workforce in order to provide a much better service. But all that happened was that the good band 5s got stripped out and promoted. The ones who were left are not that good. They struggle with then trying to step up into the band 6 and 7 roles. The trust can't recruit underneath them. And what they then do is to expand the associate nursing and healthcare workforce. And actually the people who are left really tend to struggle. They don't enjoy their jobs, then they leave. That makes the existing workforce shortage worse. And I then think that there are also really interesting questions which are asked about people who is it equitable? Who gets promoted? The current way that these jobs are entering into these jobs is structured are that you have to have a job, you need to get a bursary, you then need to be accepted onto the course. And who is it that's being accepted into these roles? And we've certainly come across examples of people saying that actually it exacerbates. We know there's problems with underrepresentations of minorities within parts of the workforce, particularly at the higher levels. And there are questions to be asked about whether or not it actually exacerbates some of this. So there are a couple of things that we came across, and I hope this will be a kickoff to a really interesting conversation. Thank you.
Thanks.
Now to do the technical bit of stopping sharing.
Thanks, Luella. That's great. So we've got a number of people on this call, I notice, who actually are really expert in this area in a variety of ways. I'm going to ask Candace Imerson, who's been has been studying this topic for a long time, to give us her thoughts on that. And I think I see Anne-Marie Rafferty is also on the call, so we might get her if she's willing. Candace, welcome.
Thanks very much, Nigel, and Luella and Alison. Thank you for fabulous presentations, which I thought encapsulated so many of the issues incredibly well. I was really minded of the title of the article I did with Richard Bomer in Health Affairs, which is now over a decade old, which was No Quick Fixes, which is, I think, actually where sadly a lot of the workforce modernisation tends to be seen as by people. And I think what you have made very clear is it's far from that. A few points I'd draw out that really struck home to me. One, I think Alison's point about the Taylorist approach, seeing this as a numbers game and not really understanding the work. And I just feel that that is such a huge omission when actually the work is changing, and that it's changing very significantly. The people that, and this is, Luella, when we did the work on medical generalism, what people in A&E were saying was that the people they were treating now were very different to the people that they were trained to treat. So there's something too about supporting the workforce to change, which has always seemed to me to be one of the missing pieces, is actually reskilling the current workforce as much as thinking about solving it from outside the workforce. The other thing it really brought home is just this horrendous gap around workforce planning in this country, which of course has existed for far too long now with nothing being done nationally, and that really does need to be addressed. And then the last point I'd make is around this issue of actually all of this workforce is working within teams, and they're teams who need to understand each other's skills and roles and ambitions, and that is a really critical part to making this all work. So thanks very much. It's lovely to be here.
Thanks, Candice. Really helpful. Anne-Marie, are you there? Yes.
Well, thanks very much, Nigel, and excellent presentations from Alison and Luella. I actually, because I couldn't figure out, talk about tech, Luella, I couldn't figure out how to get into the session. So I was a wee bit late in getting there. But I think one issue that's come up time and time again, and I think I agree with Candace in terms of understanding, you know, the sort of big picture of workforce roles and how they all fit together. It's quite interesting to think about the military and how they insist, because you can lose people, and I mean, you might draw an analogy with the NHS, we're losing people all the time, is that they train people so they understand the role above them and the role below them, as it were, in the hierarchy. So there is a kind of distributed knowledge, maybe that's partly what Alison was getting at, of different roles. And I mean, the thing that I remember talking to David Guest about, years ago, is basically job design. And he was saying, and I agree with them. And I think, you know, what we've been discussing here, the kind of guddle and the muddle and the mess of all these the different roles, is actually how they all fit together and what the key design components are. But in order to do that, you need to understand the nature of the work that's to be done. And no one holds, I suppose, getting back to Candace's point on workforce plan, no one holds that kind of totalizing view. So how do you actually do that in an organizational level? How do you make sure that those gaps are well covered, you know, and the risks inherent within them are actually there? And then there's just another point I'd make, which actually, having written a Nuffield Trust blog a few years ago, just struck me might be relevant now, which is all of this stuff is an absolute grind, you know. It's really hard work changing any of these roles. And the final point I made in that is, why do we always think we've got to invent all these roles anyway? Why can't we just try and make the existing system work better? So I think at the end of the day, I'd rather invest effort in making the existing system work better rather than add another widget into the system that might complicate workflow, workload management even further. That's my 2 pennies worth for what it's worth. Thanks.
Thank you, Anne-Marie. So I encourage you to for contributions and questions. We got things in the chat. There's a very interesting comment from several people. Farzana Hussein talks about I think something, Alison, you've been highlighting, the difference between work done and work as imagined, and the sort of negative experience of having pharmacists in these new R's roles who've got one set of skills, but it's not necessarily the ones that you need for the job. So there seems to be a repeating theme of actually really understanding of what's happening. Luella, did you want to just come back in?
Yeah, sorry. So one small point that I forgot to make, which does address Anne-Marie's issue of why these roles have proliferated, is that we have to remember that the providers of educational services are making money out of this, and there is competition in the field for who owns and holds these roads. So as Alison has touched on, there are jurisdictional issues, but there's also gold in their hills. And we see this in the proliferation of even very short courses. So sometimes 1 or 2 day courses, which claim to be able to equip you for certain types of advanced practice, which are not run by formal educational institutions. And that doesn't even get around the fact that even for universities are going to survive by expanding the number and type of courses that they offer. So part of the issue in all of this is that it is money by third parties.
Yes, that's an interesting dynamic that I think I hadn't considered before now, but it's certainly I've certainly come across it in other countries. There's a lot of people invested in these systems. Billy is one of our experts on workforce here at the Trust. Let me bring you in at this point.
Yeah, I just wanted to make a quick point. I was so struck by the comment that someone made about the R's roles, and I was just looking at the numbers here because I think general practice requires particular scrutiny about the speed in which we've seen a change. So in 2015, for every GP, there was one other clinical staff member in general practice. In 2022, 7 years forward, it's 2. It's doubled that number of other clinical staff compared to fully qualified GPs. And that's, and most of that increase has happened actually in the last 3 years. So I think it's really striking in general practice in particular about how you have had this very quick change in skill mix. And, Alison draws out through that sort of that inverted triangle about the sort of the support staff, the less experienced, the registered professionals. I think even within that registered professionals, there's really interesting sort of difference in staff being used, and some of which, are new to particular settings. So is there like an established way of using those staff in this sort of new settings, and whether policymakers have given enough thought in terms of what's the cost of trying to embed those staff in these new roles.
Thank you. That is really an important question, I think, and I was going to ask Farzana to perhaps elaborate on that, because she raised the initial point. Farzana, I don't know, you might respond to that, but also I think this point about the sheer work required if you are going to incorporate these roles. Do you want to share a bit of your experience on that, and maybe if you've got other points, make those as well?
Thank you, Nigel. Yeah, I just wanted to thank you. Well, Alison's talk has just blown me away, actually, because I hadn't heard of these terms of things like taskification, and I've actually lived it. So thank you, Alison, for putting some words to that. So yeah, back to what you're talking about, Billy. So I think there's three things. Yes, it has been very quick, so that's not possible. You know, that's just. I think you and I have talked before, Nigel, about things need a few years to, when you move from PCN's the new bride today, and then 3 years later ICS is the new bride, and this short-termism, I think that's an issue. But for me, the important thing here is back to what Alison was teaching me about this. If we break complex things up into tasks, I think there are some really negative secondary consequences. So these wonderful pharmacists are really good pharmacists, but they are new. First of all, the funding that has been given by NHS England are for pretty much brand new pharmacists in ARRS roles. So they're just doing their independent prescribing. But they're being incentivized, and we as primary care networks are being incentivized. There's been work already put onto them. So it's not a training role as a GP trainee might have for a year. There's work put onto them. So there's a lot of pressure on them. So if I give a quick example of one of the indicators is to do structured medication reviews for people who are on opioids. The task involved there's a little bit of pharmacological knowledge involved, which I agree, but the pharmacist will have more than a GP like me. But the real crux of that consultation is to think about why somebody is needing their opioids. What is it about this, addiction? What are their coping strategies? Something that perhaps a psychologist might be, better placed at, and actually as a GP, we would be able to do that. So what we're seeing is a lot of extra work. So I can absolutely say in my own experience, those SMRs have actually then come back to me. So it hasn't decreased my workload. There's been a pressure on to get these indicators, because we're very good at these short-term incentives. The pharmacist feels that they may have done something wrong, and they've done nothing wrong. This is actually not one of their skill sets. We're not trying to clone them into becoming GPs. It was supposed to be a different role given the wrong task. And more importantly, younger GPs that are coming through, salary GPs, are saying, well, I want to see patients. I don't actually want to supervise 12 different ARRS roles. So I think there's a lot of secondary consequences happening, and 26,000 roles, there's a lot of money being spent by the government into this. I don't think it's being spent well 3 years later, and I wouldn't have said that 3 years ago, but I don't think it's being spent that well. Thanks. Nigel, you're
on mute.
Someone had to do that first. Thank you. Thanks, Farzana. That was fascinating. I think this question about people having a wide range of skills which allow them to do things, it speaks to that as well. I think this cost of supervision question is a really interesting one too, which we perhaps return to. Supervising people is hard, right? It takes time, and it's not necessarily what we've all signed up for. Alison, did you want to come back on that? And I'll come to Alistair after that.
Yeah, I mean, I think Farzana's example is a really great idea. So I think the unwritten agenda behind IRS was the shortage of GP. So that's where you've got a deficit. It's in general practitioners, and increasingly I think in general practice nursing as well, which is also a traditional and well-established and workforce. So what you see is exactly that. So a pharmacist shouldn't need supervising. A pharmacist used in a pharmacy role would be highly functioning. But of course, what you then get is, because the deficits in general practice practitioners, is you get scope creep. And then when you get scope creep into a role that you're not used to doing, you're going to need the support of the person that normally does that job. And it doesn't matter what job it doesn't matter if it's engineering or medicine or anything. You're going to then rely on that. We see this a lot in people that are not nurses taking on nursing leadership roles. They're having to rely very much on nursing colleagues. So when you get this sort of scope creep, that then becomes the issue. And that, I think that was a really, really good example of not understanding the work and then therefore not redistributing the work because it's just a reactionary policy. Yeah. And ARRS didn't include, I think it didn't include general practitioners or general practice nurses, did it? It was all about adding extra people in. Yeah. So yeah, I mean, I think Kath's paper is very good on that, actually.
Yeah, and I wonder whether Kath's paper somewhat also reflects the stage of that actually this is a really hard project and it's going to take it. I mean, we probably have to do something like this, and we perhaps come back to that later, but doing it well is really difficult. Alistair, say who you are for us, if you would. I've realised I should have been doing that previously, but we'll correct that from now on.
A little bit of background, because Nigel, you and I worked together with NHS Improvement about 20 odd years ago with Derry Bell and what have you in acute medicine. So my background is I'm now a poor performing unicorn. I'm a GP partner. So background over the last few years was both hospital medicine and general practice, probably a lot more hospital medicine than most. Went through the multi-professional team development in secondary care, and I've witnessed the traditional multi-professional team or traditional GP working, and now I've moved into a partnership with a practice, large practice in the north of England. And I think he's exemplifying the best of multi-professional working. You know, we've actually managed to get out of our silos in general practice. But the biggest problem we have, we've got ACPs. In fact, I'm meant to be teaching this afternoon, debriefing this afternoon at the same time as doing clinical triage, at the same time as seeing patients, which is fine, because that's what general practitioners are supposed to be quite good at. We've got a real mixture. It's quite interesting when you look at the different professions that have come through. Pharmacy is probably the longest relationship I've had. And the biggest issue is holding clinical risk. And I think that's the biggest difference. It's the one thing the medical profession, and to some extent the nursing profession, has been taught over their experiential years, is holding clinical risk. And I've got very experienced pharmacists who refuse to. In fact, there was a big issue yesterday about the number of things that come back to the individual clinician. And I found that with other members of the team, it's quite interesting. Some of our ACPs are in fact providing an incredible service, and some, I want more GPs. Our practice is based on the east coast of Yorkshire, and you can't recruit. So there are some practicalities here around using ACPs. Ideally, I'd like more GPs. But I think it is interesting how things have developed. And I don't think we're going to get away from those professional teams. And if done correctly, I think it is the best way of delivering patient care. So that's just my start of a tone. Thanks.
Thank you. Yeah, I mean, I think this point that in some cases we may have no choice but to expect to think about the role. So it may be more a question of how it's done. Mark, you've been monitoring the chat a bit, and I think you've spotted a theme that we might put to the panelists and indeed to anyone else in the meeting to think about. Can I come to you to just articulate that? Do a synthesis of that.
So a lot of sympathy and a lot of examples with the concept of taskification that Alison raised. But another point that's been raised by a few people in a more sort of policy, what could we do about this space, is there a solution to the proliferation of roles that Alison described? Should they be reduced to fewer? Should we have a more centralized system? And what's the role of regulation in maybe defining this and trying to get it down to fewer, better understood and evaluated types of staff?
Alison, do you want to? What's your instinct on that?
Yeah, I mean, I think the roles are confused. The role titles are confusing. They're confusing for employers. They're confusing for patients. They're very confusing for commissioners. I've found commissioners don't really know what they're commissioning. So, I mean, I think rationalisation, but I think it's also important to understand why they proliferated in the first place. So particularly in nursing, we saw that as reward instead of money. So just give you a more fancy job title, not higher banding. And then we see job titles being misappropriated. So the group that I work with most is clinical nurse specialists and district nurses. You used to have to, they are advanced practice roles in nursing, not medical substitution. In nursing, they are advanced practice roles. And they are now misappropriated to sort of newly qualified people without the appropriate qualifications and experience. I think there's also something about the speed of which people now go through the system. So as an AMP, I was practicing for about 10 years before I worked in advanced practice, and now 2 or 3 years out, you can do, you're doing the ACP course. So I think that's the thing about holding risk. Actually, I learned to hold risk over time, and not necessarily hold risk, but I think Rebecca Myers says it in the chat actually about the reality of holding risk. So I was comfortable with the reality of holding risk, and that's, we have a largely rookie workforce now. Lots of people qualified less than 2 years, providing frontline services. You particularly see this in the ambulance service. It is unsurprising that we have a proliferation of roles and people going off in lots of different directions. And I think that's one of the things we have to address. And the big thing is Taylorism. We have to address Taylorism.
Thank you. Any other thoughts on that question? I mean, because there is a tension, isn't there? We do also want to have people with the ability to, the roles that you might want to design for, the east coast of Yorkshire, where it's hard to recruit GPs, might be different from what you need in other practices. There's a tension here between. I also slightly worry when we about saying to NHS England, would you please, or HEE, would you please go and design a central process to answer the question, which makes us. We've got limited experience on that. And any sort of thoughts or reactions on that from people? I've got Alistair, you've got your hand back up again, yeah, and then I'll come to Luella.
Yeah, just a quickie, Nigel. We're a group of 3 large practices: Hull, Scarborough, and York. We have absolutely no problem recruiting to York. We've just appointed 4 partners. It's rather like the old Edinburgh Royal Infirmary situation, where you had to bribe new consultants at the Royal Infirmary to do sessions out of West and East Lothian. We tried the same, but unfortunately it seems that modern new partners struggle with the commute from York to Scarborough for much longer than 6 months before throwing their hands up in horror. I think it's horses for courses. You've got to adapt to your local environment. Yeah. Not all fixes will work in all places.
But we probably could definitely do with some more standardisation, I suspect, from what Alison's saying. Thank you, Luella.
Yes, so of course we have to remember that HEE has in fact put out for England, it doesn't apply to the devolved nations, but HEE has already put out guidance for all advanced clinical practice, not just nursing, but all of these other types of practitioner. And despite this, we still see the mess that we have. So HE taking on isn't actually the solution to all of this. And I think that one of the things that has come up in our other discussions is the use of other regulators and other mechanisms, in fact, to fix the problem. And the CQC issuing guidance about what sorts of oversight should be put in place, that would then certainly also apply to general practice. Tightening, there is the issue of it's just not a single time point around regulation, because regulation is usually you get put on a register. There's what happens after that. And then that also draws up all of the interesting questions is, the way it's done for doctors, we know it doesn't work properly. It's put in place for shipment. Would my current relicensing and revalidation process have caught shipment? No, it wouldn't. So in fact, all of this is in fact, vastly complex. And it really requires a consent. We've seen in Northern Ireland that there has been a consensus between the educators and the employers, and their other organisations of oversight. But that's because they're small and they're cooperative and they've been able to actually do it. So regulation and oversight from single body isn't necessarily the way to do it, and it requires desire and a genuine, and just showing people genuinely that doing this will in fact work. And whereas at the moment, I think everybody's just desperate for more staff.
Good. So I'm just looking at Crystal. Crystal Elman has asked a question: is this politically driven by the requirement to do something? I think probably in some cases, yes. Although I think most of these new roles have been developed either they're local responses to problems. So it might be small P political rather than big P political. And the national things like ours roles very much a product of NHS England, I think, rather than being driven by ministerial the good ideas. although that is always a hazard. Alison, and maybe Luella, you have a thought on this. There seems to be a distinction emerging in some of this conversation about a distinction between sort of using skill mix within a professional silo and then using it to expand across professional silos. Is that a distinction that where there's a different sort of some conceptual differences, and we've heard particularly in this issue about managing risk, that when you ask people to perhaps work from the one silo they're in across into another, that then the risk holding then becomes an issue, whereas expanding roles of nurses within, and it's more of nursing rather than being a substitute ST3. Is there a sort of conceptual distinction to be made there, and does that provide us with a bit of a sort of tin opener into thinking about some of these issues in a different way?
I think certainly for things like ACP, yes, because it's essentially being a novice in somebody else's jurisdiction rather than advanced practice in your own field. So yeah, there is that. So if you look at an advanced practice nurse, say a district nurse, they will have a huge amount of knowledge, skills, experience in district nursing, and quite often they do pick up some of the tools of medicine that were traditionally medicine, for example, prescribing or being able to do a physical assessment, but they're not practicing medicine. It's a sort of advanced practice nursing. And then, of course, with the substitution type roles, people are then shoved into somebody else's territory. And that can do one of two things. That can either people who are traditionally in that role will try to control that role, which is what's happened. The Royal Colleges have taken over ACP, so taken over other professions' jurisdiction, in a sort of attempt to manage risk and control spread, which happens quite a lot. Or there's pushback. You're not coming onto our territory. So there is definitely that. I think the thing about silos is silos are I think a bit of a misnomer. Everyone has a technical area of knowledge and everyone has a different view on praxis and a different lens that they look through. And together, if you get that working well, you've got a fantastic MDT. And everybody's bringing something different to the table, and they might be bringing similar technical skills, but they'll bring a different perspective. Once you start trying to mash everybody together and break down the silos, then I think something actually very, very important is lost.
Yeah, that's really interesting. So valuing difference is important. Luella, did you have a perspective on that?
Yeah, so we've seen a couple of good. So I've seen a couple of good examples, because I'm very interested in small, rural, and remote hospitals, of task force based across medicine. So what skills do you need in order to cover a smaller acute hospital at night? So you need someone who can think, and then there's certain actual task-based things that you need someone to be able to do. And sometimes both of those things are embodied in one person. So the intensivist who can tube and run something, and can they run an arrest? Well, maybe they can, so you can pair them up. So we've seen we've seen one or two examples of really kind of good task-based. So instead of having one anaesthetist, one intensivist, one ITU doctor, one physician on call, one surgeon on call overnight, actually looking at what the critical task of those are and actually putting those across. So I've seen a good example of that. And of course, the other really important example of this is EICU in the USA. So there are just not enough intensivists to cover all of the small ITUs across the USA all of the time. And so again, the notion of someone being able to cover during the day, make decisions, set plans, and then the patients being remotely monitored overnight, so long as there is a nurse or some other form of practitioner who is able to put a tube in, can probably do a tracheostomy if they need to, put in a central line. They are actually able to oversee that. But that's a model that's developed over time. It's not without its problems, but it can in fact actually work if it's executed thoughtfully.
Yeah, thoughtful execution seems to be a bit of a theme. I want to pick up, there's a comment from JKM Care. I don't know, that name obviously belongs to a real person, perhaps, about taskification, which I think was linked to an earlier comment they made about automation. And I just wondered, maybe Alison, but others might have a view on this, about the link between taskification and burnout. not just for the people, and whether that has got different effects on different types of people. I mean, so my concern about the working at the top of your license is that it may well be more conducive to basically quickly burning out, which does seem to be an issue in a lot of countries, and particularly countries with more of a Taylorism approach to the world. Just whether you or indeed anyone else got perspectives on that question. I hope I've done justice to JKM. If you want to come in and add to that, please feel free to do so. Put your hand up, and I'll bring you in. But Alison, while they think about that.
I mean, I think the top of the license. Yeah, I mean, I have antibodies to that. I'm very outspoken against it because it's about maximum productivity all the time, and you can't do that to people. One of the issues that we have is we still have that form of workforce planning in the UK, in all 4 countries in healthcare. We have not yet moved to humanistic workforce planning. And if you have 5 minutes, Stephen Shorrock gave a really good talk yesterday for Scottish QI network. But we really haven't seen, we're still in this sort of biscuit factory mentality. We're not seeing the workforce as people. And that's really holding back, I think, any kind of issue, a lot of the issues of retention. So taskification, where you see the complex work as just the division of labour, you break everything up, you give it to people, can intensify workloads, yes, particularly as Fazana said, if you've got to have people come back and check the work, so you're just intensifying work. I think what JKM says, because we speak quite a lot, is actually the work that is now in the system that has intensified workloads that could be done automated, and I'm very keen on that actually. So good example is just, we did a project in Norway where we introduced wall clerks for 12 hours a day, and it released a huge amount of time for nurses and doctors actually. So, having a mixed workforce that can do more of the administrative work, particularly the administrative work burden in healthcare generated by technology is huge. I'd not appreciated it until we started looking at it. So a lot of the technology that was brought into, we're just about to release a report on district nursing in this, a lot of the technology that was brought in to help is actually making workloads more intensive. So yeah, I mean, I think there is a lot around that. Do you want
to say a little bit more about how that's happening, because that's very counterintuitive, and it does seem to be because we're not getting the productivity bonus that we've been promised from quite a lot of this digital technology. What's been going on there?
Essentially, in that workforce, it is the work imagined work has done. So technology is deployed to solve a problem that is not the problem that people have. And then you've got the functionality of technology. So, the nuts and bolts, waiting 20 minutes for the thing to log on type of stuff, but also the actual function of it. So if the function is not designed for the user, then it can cause workload intensification.
Great, thanks. I've got Luella and then Paul Rylance, who is JKM Care Solutions. Luella.
Yeah, so just very quickly to say that some of the things that we dismiss as menial tasks are in fact incredibly complicated. So the best example of this is one of the things that the junior doctors hate more than anything else and view as the most menial scut monkey job is doing the discharge summary. Well, the simple fact of it is that something like 80% of patients experience some kind of major error in communication between the hospital and the GP. This is an absolutely and utterly, it is a mission critical task to the hospital, to the hospital episode of care. I can do whatever I want to the patient in hospital, and if the discharge summary is not right, they might as well not have been admitted because they're going to come back. And so one of the problems is the anatomization of that. It is tasked off. It's given to someone who doesn't know the patient, doesn't know the rest of the team, doesn't appreciate how important the task is. And that's very different from my experience of it as a very junior doctor, where it was considered to be one of the most critical things that was done. And my doing that well was really important. And I was taught how to do it. and there were penalties for not doing it well. And instead, we disregard it. It's regarded as menial, and the juniors hate it, and they hate it to the point where they put tweets out saying, I had to do discharge summary as service provision, I'm leaving my job, instead of it being viewed as something that is absolutely and utterly mission critical. So we frequently underestimate the cognitive value and the value of these tasks to the patient. And I think that's also a really big problem that we miss in all of this.
Mm. You've hit a nerve there with various people who are on the receiving end of the discharge summary process, Luella, I think. Paul, and then come back to Alistair.
Yeah, thanks very much, Nigel. Very quickly, a lot of technology is creating these tasks, and then it delves them out to a number of people, and that's adding zero value. And that's not what technology should be about. A great example is delayed transfers of care, or DTOC. If somebody's delayed, then a computer system telling a person that they now have to raise a new discharge notice and a new assessment notice and rearrange transport and rearrange medical or medications is zero benefit. A system should be doing that automatically in the background, on cue, from the right staff. I'm hoping that makes sense. I'm sorry if I'm sounding geeky.
No, that's absolutely. Alistair, I actually might want to come back on the discharge question, which is really, yeah.
Thank you. I couldn't agree with you more. It's just astonishing how it's changed. I mean, I've worked through clinical medicine since the days of teams to the change in hospital-based teams. So it is often someone who's completely ignorant of the patient, what the consultant said, what investigations have been done. It is just amazing. The one good thing is and I do remember this starting in Edinburgh before I left 7 or 8 years ago, we've managed to get some pushback in primary care to medical directors in secondary care to actually, a lot of the traditional discharge letter use of the GP as some sort of extended house officer in the community has been pushed back, and it does improve the letters and improves their planning. But it's an astonishing amount of work we generate. We talk about patient handoffs. I mean, this is a clinical team handoffs, and it is reducing, but it's a huge area of concern, huge, and a huge workload.
Good. Any other thoughts or comments on that? I'm just looking at other comments in the chat. There's some great stuff. Mark, anything else that's come out from your looking at what people are doing?
So I think we've covered some of it. An interesting question much earlier was how this might compare with the situation in social care, where roles are more flexible, but have also been criticised for being very task-oriented in how they're arranged. I wondered if there were sort of other adjacent sectors that offer relevant examples.
Billy.
Yeah, I'm conscious of the timing of the much promised national workforce plan, and we can assume there will be quite a bit on skill mix and staff mix, because there's only, international recruitment is sort of limited by opportunities of which professions you could bring in that way, and the domestic pipeline and the length of it for some professions mean there's some limitations there. So we can assume there'll be quite a bit said, and I'm intrigued to know what people hope to see and hope not to see when it comes to that finally hitting our inboxes. Because people have articulated some issues, but in terms of what they want from national workforce planners and Department of Health and the arm's length bodies, I think that'd be interesting, because that's one level of this that's dictating some of it, and then there's there's individual practice that we see from employers and perhaps what ICSs are doing, but just from that policy perspective.
Good. Any immediate thoughts or comments on that people have got? Because otherwise I'm going to ask you to do something if you could. Let's see if this works. In the chat, you should see a link. In the link, there is a link to a Mentimeter poll, which I'd like to see what's the key insight you've taken from this conversation that ought to inform policy, regulation, or management in future, and just let's see, just sort of test where you've got to, and we'll then is it working? That's the question. Sort of slight anxiety with the technology, but let's. Oops, what's going on there? That's not right. Oh, it is working. Good Lord. I should also be showing my screen. Has that worked?
Yes, it is work, Nigel.
Oh, right, good. Oh, the slight problem is I seem to have lost my Zoom window. So taskification is the not less than elegant word of the day, it would appear. I think for me that really came from this insight of actually not really understanding what people actually are doing and what lies beneath what they're doing. What are the sorts of, what's the context and that they're doing it in, and the sort of skills, knowledge, and this other word that that goes with it, Alison, I think is praxis. And if you just see the sort of the surface, you can then put it, you can then create tasks.
It's interesting, isn't it? Yeah, I mean, practice is just a German word for application of knowledge and development of practice. You know, if you read books like 10,000 Hours, you know, that kind of thing. Taskification is really. I'm an engineer by background, and I learned to do the modelling for workforce at MIT. So, taskification is a very engineering word. So I am sorry.
So in medicine, historically, the word is methodus. So the word for cognitive skill and thinking is methodus. So the RCP used to judge you on whether your methodus mendendi, your method of thinking, and your disposition, yes, and your disposition were appropriate for you to be a physician. That is what you were judged on.
Yeah.
And we've kind of lost that with this kind of competence-based and skill-based approach, I think, in medicine as well. Cognition isn't recognised for how important it is.
Yeah, I mean, we know that the work of healthcare is high on technical burden, cognitive burden, emotional and relational labour, and for nursing, organisational labour as well. So, you know, we know a lot about the labour demands.
So we're going to pick up the question of the administrative burden on frontline staff later. I mean, I think Alison, Luella, others, I think we're not saying that there isn't that we don't need to do some create more. We will need to create new roles to deal with some of the issues that we face. There are advantages to doing it in some settings, but doing it is probably much more difficult than we've imagined. It needs a deeper understanding of what you're doing. It will take time to embed and needs to be done with a high level of skill, and that the risks involved in creating roles which then require lots of supervision and add to work are quite significant if you don't do it well. And that there's a very big sort of overall sort of regulatory education and sort of more general sort of thinking about some of the machinery that oversees this and how that works that also needs to be done, and that probably we have in some cases done this too thoughtlessly, and with too much sort of individual small individual effort, not really based on a full understanding of what people do. But I don't think we're saying this is the use of skill mix and of role substitution and role expansion is necessarily a bad thing. It's just hard to do well. Would that be a reasonable summary, Luella, Alison, of what we're saying? so rather more nuanced than the approach that's been taken by some bits of the national policy machine. On that basis, I think I'm going to say thank you very much to everyone for some fantastic input from people. The next event is in the chat. And as I mentioned that, we're going to look at some of these issues about the administrative burden, and we're framing that as the let's just put more money into clinical frontline. And in fact, in some senses, we might well argue for some substitution. So the ward clerk, the idea of ward clerks and other types of administrative help to reduce the administrative burden might well be, from what Alison's saying, a more profitable way of thinking about how we do substitution and new skill mix, although I can't see it selling very well with the Daily Mail or MPs, but never mind. So thank you, everyone. Thanks particularly to Alison and to Luella and to the events team here, Mark and Leonora, for monitoring the chat, and to all of you for participating, and to Billy for helping with a bit of input there as well. So great. Thanks, everyone. We'll see you next time, I hope.